I want to thank everyone for joining us for our Sunday night lecture program. As always, we hope everyone is well and safe. Dr. Alan Kadish serves as the president of the Torah College and the University System. He is our guest lecturer this evening. He is Torah College's second president ever, a position that he began in March 2010. And prior to his role as at the helm of Torah University, Dr. Kadish was a prominent cardiologist, teacher, researcher, and administrator. He taught at the University of Michigan and held a 19-year tenure at Northwestern University. At Northwestern, he was a senior associate chief of cardiology, director of the cardiovascular clinical trials unit, and sat on the finance and investment committees of Northwestern Clinical Practice Plan. He has published over 250 peer-reviewed papers and received numerous grants. And while during his time at Torah, he helped expand and strengthen many of its schools, including 2 colleges of pharmacy, 4 colleges of medicine, and graduate schools and programs in health sciences. Now, Dr. Kadish has been highly involved in the COVID-19 discussions. Already in January, while the virus was still contained in China, he anticipated the effects of the virus, of the epidemic upon the world population, and he convened an event in Midtown aimed at educating the media and general public about the potential dangers of the virus. Now, recently, he addressed the Board of Governors of the Miami Beach Chamber of Commerce regarding COVID-19, and he joined the president of West Virginia University in a discussion highlighting the future of higher education post-COVID-19. And as you all heard, many of the universities are now grappling with what they should do exactly in September, how to educate the students to the best of their abilities, by as well as keeping both the students and the staff safe. So he's deeply involved in those discussions. Dr. Kadish was supposed to be our scholar in residence for Shavuos this year. So maybe if we could already reserve you, please God, for next year. But instead, we have the honor to have you address us tonight. His topic is Torah in the age of COVID-19, allocation of limited healthcare resources. He's going to give a Torah presentation, but he mentioned that as an expertise in many fields, he will be available for question and answers afterwards. Anyone who has a question could just type it in, and we will share the question with Dr. Kadish. So it's a great honor to introduce him. But I'd also like to welcome and to thank Rabbi Alan Senior, an old friend and mentor of mine who arranged this evening's program. It's always a pleasure to do anything with you. So thank you for arranging tonight's lecture. Dr. Kadish, please.
Thank you very much for the kind introduction. And I too look forward to being able to see everyone in person at some point, hopefully sooner rather than later. If I had to look back on how, quote, experts, both medical and political, understood what was going on with COVID, I would divide things into 3 phases. The first phase was when everyone underestimated what was going to happen. The second phase was when there was panic that everything in the healthcare system would be overwhelmed. And the third phase is where we are now, where we've kind of reached somewhat of an equilibrium, and perhaps we can talk about that during the question and answer period, as Rabbi Babich suggested. But during the phase when people talked about 2 million people in the US dying and having resources that were inadequate to deal with the epidemic, one particular issue came up that has some very interesting questions that are raised, both philosophically, morally, and halachically. And it's been talked about before in a variety of recent shiurim, but I thought I would give you my own perspective, just perhaps a little bit different, on the question of how do you allocate limited resources during a pandemic, and in particular, the issue first arose with regard to ventilators. It was thought that there would be, particularly in the New York metropolitan area, a huge shortage of ventilators, a combination of predictions of very high case rates and a shortage of ventilators due to failures in the supply chain, and the combination of those led to what was thought to be coming a shortage of ventilators, where all the ventilators in a hospital or a healthcare system would be used. People who needed a ventilator would come to the emergency room and ventilators wouldn't be available. And the question arose, how do you allocate a scarce resource such as ventilators in that circumstance? Now, because this is primarily a halachic discussion, I'm going to sort of temporarily ignore two issues. One is the fact that perhaps ventilators were overused in patients with SARS-CoV-2 infection. And secondly, that there are techniques for sharing ventilators. So for the purposes of at least the beginning of the discussion, we're going to ignore those two things and assume that indeed there was a shortage of ventilators, and we have a situation where multiple people come to the emergency room, there aren't enough ventilators for everyone, or all the ventilators are used in the hospital, and there are no ventilators for anyone, and diverting patients to another hospital is not possible because they're in the same situation where ventilators aren't present. So that's the issue we'll try to deal with in a few minutes tonight. So to start out, I'm going to talk a little bit about, spend a few minutes talking about some basic aspects of the medical decisions in terms of life-saving therapy, accepting it, withdrawing it, and so on, in the absence of limited resources, as a background for trying to decide what we ought to do in the case of limited resources. And this first introduction is really several talks in of itself, so I'm going to deal with it very superficially in the interest of time. And so I apologize to everyone for that. So the first principle is the principle, of course, that there is a Torah principle to preserve human life. Interestingly, what exactly the origin of that commandment that we're required to preserve our own life as well as other people's lives is not clear, because different commentators cite different passages in the Torah to discuss that. So just to let you know how extensively it's been discussed, there's actually a book written in pre-war Berlin by Eliyahu Feivelstein, which is shown now on the screen. I hope you can all see in reference 1. And it lists a large number of potential sources for the commands to save lives. And you can see there are actually about 17 sources that are listed here. Interestingly, the ones that are most often cited by halachic authorities regarding life-saving are V'nishmartem le'od lenafshosechem, that's the second reference shown on this page, or the first one, Rak hishamer lecha u'shmor nafshecha. So you should watch yourself and watch your soul and be careful about your soul. The simple explanation of both these passages is it's actually referring to spiritual salvation, but it's been adapted halachically to refer to the commandment to preserve life at all costs. The third reference on this page, V'chai bahem, is another one that is commonly cited as the idea that one has to live with biblical commandments, that one is not, with some limited exceptions, one is not supposed to die. And finally, there's a typo, I apologize, in the last two references there, but the one that it refers to is V'rapo Yirapeh, the passage that talks about what happens if you damage someone else. that one of the things you're responsible to reimburse them for is medical expenses. And this passage, V'rapo Yirapeh, that you will surely heal, is interpreted both as the passage that allows physicians to engage in their profession, as well as a passage that many say is a positive commandment that one is required to heal others. So there is a commonly accepted biblical commandment, as I said, although there are multiple sources that are cited, for the preservation of life at all costs. And there, I would say there are two philosophical components that underlie these commandments. One is the idea that life is a gift from Hashem, it is a gift from God, and we must preserve that gift at all costs. And the second is the idea that our purpose in the world is to fulfill the mitzvot, fulfill commandments, and we're only able to do that as long as we have our life giving us the ability to continue to fulfill commandments. So we have a general precept of the requirement to preserve and prolong life. So how does that translate into some general principles, and are there limitations to it? So some of the general halachic outcomes of these commandments are, first of all, that suicide is generally forbidden, that when there's a medical therapy that is widely and generally accepted to have a very positive risk-benefit ratio, that one is not allowed to refuse that therapy. So, for example, if you have a cancer that's easily curable, from a halachic standpoint, it's not permitted to say, I don't want to accept the cure, I want to die, as long as the cure is relatively efficacious and doesn't contain huge numbers of side effects. Now, there are some qualifications and exceptions. And none of these qualifications and exceptions are simple. And so each case requires a careful halachic analysis. But for example, if there's a therapy, let's say a cancer therapy that has minimal ability to prolong life, but is associated with substantial side effects, patients can refuse that therapy. So although in general, in halacha, patient autonomy does not rise to the same level of analysis that it does in general medical ethics, a topic we'll discuss in a moment, there are cases such as highly toxic therapies that have limited benefit, where patient autonomy is respected and where patients have a choice. Do I want to accept this therapy or don't I? There are even some cases when refusing therapy is thought to be the right thing to do. For example, there's a story from about 30 years ago where a famous rabbi in Israel had something called a thoracic aneurysm, which is an out-pocketing of the major blood vessel that comes out of the heart, the aorta, and that was involving several of the arteries that are crucial to survival of the heart and the brain. And although this wouldn't be true today, at that time, the surgeons in Israel were very good, but there was some limitation to what they could do. And their feeling was that although the mortality was close to 100% if surgery was not done, that the mortality would be over 50% from surgery. And this rabbi's feeling was that having an operation where you had more than a 50% chance of dying on the table, regardless of the potential long-term benefits, that was actually not justified. And so he refused the therapy. The end of the story is good. There were actually some surgeons in the United States that were more advanced. They quoted him a less than 50% mortality. He came here and had the surgery and survived and did well. But the point is, there are some limitations to the risks that one ought to take, at least according to that opinion. A second qualification is that there's a fundamental difference between refusing therapy and withdrawing therapy. So the general principle is that if people are terminally ill, and there's some halachic terms that refer to that that we'll discuss in a few moments. If someone's terminally ill, you're not required to institute aggressive therapy. You must always provide some basic things, exactly what basic things are: food and water, perhaps some other things depending on different opinions, but you don't necessarily have to engage in aggressive therapy in someone who is otherwise terminally ill. However, that's different from withdrawing therapy. You can't withdraw therapy if withdrawing that therapy will cause someone to die immediately and with certainty. So for example, if you have someone who has a pacemaker and they're dependent on the pacemaker, you cannot turn the pacemaker off if it will result in their immediate death. And more relevant to today's discussion, if you're on a ventilator, even though you might not have been required to be put on that ventilator to start with, once you're on the ventilator, it cannot be summarily removed if you're not able to breathe on your own, and it would result in immediate death. There's one other qualification based on a Gemara, which has to do with the difference between removing something that prevents you from dying versus doing something that hastens death. So an example is given if there's someone seriously ill and there's noise going on outside, and that noise is sort of agitating them and keeping them alive, that it's okay to remove that noise, to remove, in halachic terms, the monea, but you couldn't do anything directly, like removing something from the bed that's helping them breathe. And that's a distinction between active engagement in hastening death and passive or indirect activity. So that's a brief summary of, and as I said, it's very vague and very general in the interest of time, but that's a brief summary of the general ideas about life prolongation. But all of that relates to a situation where resources are not an issue. We're only talking about patient survival. So what about the case where there are limited resources? So there are a few additional things that are required here to understand. And one is, there are actually, although we value life and we have a principle of ein dochim nefesh mipnei nefesh, we can't push aside one life for another. And let me try to, and in the references that are on the page right now, it talks about the cases where you have a group of Jews that's been captured or attacked by others, and they've been told that you have to hand someone over, and if you don't hand that person over, you'll all die. And there's a disagreement in the Gemara about what the halacha is in that case, but there are a few cases where it's clear, and where it's clear is if no specific person is asked for, and you have to make the decision about which person should be sacrificed, the halacha is you should all die rather than hand over one individual. The exceptions may be if a specific individual is asked for, or if there's a person who has committed a capital crime that's being accused that is asked for. Those may be exceptions, but the general principle is we can't judge which person is more important. And the halacha appears to be that even if more people will die, you can't hand over one person unless that specific person's been identified based on guilt. So that's one concept that talks about balancing different lives, or allocation of resources. It's allocation of resources because there's another case in the Gemara where there's only water for one person. The question is, how do you divide it? The second issue, that, by way of background, is that there are, even though we have this principle that all life is created equal, there are different categories. There's someone who's going to die in the next couple of days, called the goses. and someone who will die in the next 6 to 12 months, called Chaye Sha'a, meaning he's only going to live for a certain period of time, and then a halachic category called Chaye Olam, where someone will live, of course, not forever, but where they don't have a disease currently, which will limit their lifespan. So there's a very famous philosophical problem that deals with how to deal with issues of who's going to die. And it's called the trolley problem. And the trolley problem has not been discussed too much because it kind of reached a state where philosophers didn't have much to say about it. But here's the problem. You're in the picture here, you can see that there's a man who is standing by the trolley, the switchman, and he sees that there are 5 people tied to the track where the trolley is going, and 1 person tied to an alternative track. And then he has a choice. Should he divert the trolley towards the 1 person, saving the 5, or should he let the trolley continue on its own and kill the 5 people? And so the different philosophical arguments regarding this are described here. There's a consequentialist view, which is the idea that you should create the greatest good for all. So what that means is you should move the trolley because only 1 person will be harmed as opposed to 5. The categorical review states that it's the action itself which needs to be evaluated. And by moving the trolley, and I'm going to frame it a little bit differently than in the text here, by moving the trolley, you're taking an action that will result in somebody's death. And that action is not justified. The third view talks about non-participation, which is leave everything alone, which results in the same outcome as the deontological view, but it's based on a slightly different philosophy. There's a variation to this theme, which is called the fat man problem, which is shown here, in which you once again have a trolley that's about to kill 5 people. And there's someone you can push down off a bridge who will stop the trolley. And in the fat man variation, now the active action is to actually put him off the bridge, not divert the trolley. And the question is, are you justified to push that person down? So surveys as shown here show that most people are willing to divert the trolley by pulling the switch, but not to push the person down. There's perhaps a moral and philosophical distinction, but the general outcome sort of seems the same. What's the relevance to the ventilator case that we discussed? In this case, by the way, a variation of the fat man problem would be you have someone in the hospital whose organs can save multiple people. Do you kill them to utilize the organs? And almost no one would say that one would do that. And why that's different is something we'll try to discuss in the next few minutes. But what's the relevance to ventilators? In dealing with ventilators, you're usually not dealing with multiple people rather than one, but you are dealing with evaluating or valuing one life versus another. And the question is, particularly as it relates to removing a ventilator from one person to give it to another, how do you morally, ethically, and halachically view that distinction? So before we get to the ventilator issue, there have been some things written halachically about the trolley problem. And the most cogent answer is written by an Israeli halachic authority. This was written near the end of the last century, relatively recently, who asked the questions. The second question is the one we'll focus on. Are you allowed to save many people by way of killing one? And his approach is that the answer is no. He reflects on one of the great halachic authorities of the prior century, the Kadish, who struggled with what to do with an earlier version of the trolley problem, but with the same idea. And the Tzitz Eliezer of Waldenberg concludes that one is not allowed to actively kill or serve up one person in order to save others. What was the Chazon Ish's idea that perhaps one could? So his idea was that even though diverting the trolley will result in someone's death, the action itself is an action of saving people. And so the death that occurs is a necessary and inevitable consequence, but the action itself is an action of saving people, as opposed to the fat man problem, where you actually are doing the reverse. That is, first and foremost, you're killing the fat man, and secondly, you're resulting in an action of saving other people. So before we delve into the issues of how you allocate ventilators as a limited resource and whether it's permissible to take one person off a ventilator to save someone else who perhaps has a greater chance of survival, I want to try to touch base a little bit on the distinction between the halachic view and the medical ethics view of this. Now, when we talk about the difference between the halachic viewpoint on pikuach nefesh, on saving lives, and modern medical ethics, usually the most prominent distinction is based on patient autonomy. That is, Western medical ethics views patient autonomy as the most important principle behind decisions. There are limits to patient autonomy. Only a few states allow assisted suicide, but patient autonomy and patient choice is thought to be the most important value in Western medical ethics. In contrast, in halacha, while, as I mentioned, there's a role for patient autonomy, preserving life is the most important ethical value. Now, it turns out that in dealing with allocation of resources in these cases, patient autonomy is generally abrogated to a large extent in Western medical ethics. So it eliminates one of the most important distinctions that often relate to the issue of halachic analysis versus medical ethics analysis. However, as we'll see, there's another important distinction that shows up. So this is from a recent New England Journal of Medicine paper looking at various approaches to triage when you have limited medical resources. So if we look at these principles and try to compare them to the halachic principles and look at where things stand, the primary principles that are utilized are to save the most lives and to maximize prognosis at the expense of some older ethical principles, which figure prominently in halacha, which are first come, first serve, and random selection. Those principles, we'll see, are utilized by some halachic authorities to allocate scarce resources. One of the more modern ethical principles that has replaced first come, first serve, or random selection is the equivalence principle. And what the equivalence principle says is that I don't care who's gotten there first, and I don't care if someone's already been treated or connected to a ventilator. I'm going to make an ethical and moral decision at time zero, no matter what. So what does that mean? If I have a patient who's come to the emergency room and I've started treating them, and that patient is a 75-year-old, and I've determined they need a ventilator, and I've put them on a ventilator, but they're not doing particularly well, although it's too early to know what the outcome will actually be. And now I have a 25-year-old who comes to the emergency room who has a ventilator. I should remove the ventilator from the 75-year-old and put it on the 25-year-old because they're likely to survive. And the fact that the 75-year-old is already on the ventilator isn't relevant to my moral and ethical decisions. And there were several ethics committees that had planned to utilize this principle in allocating ventilator resources, even though it probably never became relevant because this was happening during the second period when we overestimated the need for ventilators and overestimated the size of the pandemic. So what about the halachic principles of both triage and removing therapy? So let's first look at a couple of sources that talk about triage. In reference 9 showed on the screen here, this is from Rav Moshe Feinstein. In many people's minds, the foremost halachic decisor of the late 20th century, of the mid to late 20th century, talks about the fact that if one person comes first, you start treating the person who's there, and you don't abandon that person if someone else comes. And however, if both come at the same time, then you can use a variety of principles to decide who gets treated first. So in the reference shown here, he talks about the fact that if someone is in greater danger, you treat them first. And if someone has a greater chance of survival, particularly may survive for a long period of time, as opposed to the Kadish we talked about, that you should treat that person first as well. Those principles are agreed to by most halachic authorities. And in reference 11 here, it talks a little bit about the background for why that's the case. And basically, there are two halachic approaches for determining why that's the case. One is the one brought down here by another late 20th century halachic authority, early 21st century, late 20th, early 21st century halachic authority in Israel, who says that if we've already established the fact that it's a positive commandment to heal the sick, and once you're engaged in that positive commandment, you can't pull away to do something else, even if it's another mitzvah. In halachic terms, ha'osek b'mitzvah patr min ha'mitzvah. The other general thematic approach to the idea that you can't stop taking care of someone once you've started, even if you have a patient who has perhaps a higher chance of survival, is the idea of ein dochim nefesh mipnei nefesh, which we discussed previously, which is that you can't decide that one person's life is more important than another's. So where, as far as triage is concerned, the chances of success of therapy and how sick someone is are important factors in deciding that. If someone has chaye olam versus chaye shah, meaning that they may live for a long period of time as opposed to they're terminal for other reasons, that's also a factor in terms of deciding who comes first. And so there are halachic principles that are generally similar to medical ethical principles that define who comes first. There is what I would say is a very minority opinion in reference, shown here in reference 12, that suggests that the Mishnah's old idea that we value certain people's lives above others might be applicable in this situation. It includes the fact that a Kohen is more important than a Levi, who's more important than a regular Jew. But almost all halachic authorities believe that that process, which is shown later here in reference 17 from the Mishnah in Horios, that no longer applies currently. And the halachic reason for it no longer applying currently is twofold. One is, we don't necessarily know who's a Kohen or a Levi anymore. But secondly, the fundamental idea behind, as I mentioned, there are two fundamental ideas behind preserving life. One of those two is the ability to perform mitzvot, the chance that you will continue to perform mitzvot. And unlike in the time of the Beis HaMikdash, where the Kohen and the Levi and others had more mitzvot to perform, that's no longer relevant. So almost all halachic authorities ignore that particular process of selecting who will be chosen. So if one had to look at what are the distinctions in triage between halachic opinions and general medical ethics, probably the fundamental difference in triage is simply age. Several halachic authorities shown here in references 13 and 14 and 15, Rav Hershel Schachter, Usher Weiss, Avram Steinberg, all say that the age of a person is not relevant to that decision. Whereas I showed you earlier, maximizing years based on age is considered part of many people's medical ethics decision. Terminal illness, however, is considered both halachically and in terms of medical ethics a basis for making a triage decision. The place where there are more differences is removing resources once someone has been given the resource, or in a case where people don't appear simultaneously. And in that case, as I mentioned, medical ethics has suggested currently that actually removing therapy to maximize benefit based on the equivalence principle is acceptable, whereas halachically it's considered generally not acceptable. However, there are some exceptions. And those exceptions, some of which have been developed only in the last few weeks during the COVID crisis, are the following. One, if you're in a situation where you know that other people are going to come to see you that day, even though people don't appear simultaneously, you can allocate resources according to some authorities based on that. So for example, I have someone who's critically ill who comes to the emergency room right now. They need a ventilator, but I believe based on my experience that they have almost no chance of survival, even if they're placed on a ventilator. As you know, during the COVID crisis, in some hospitals, there was a 95% mortality once you got on a ventilator. So the idea that if you practice in that kind of an environment and you have someone who's really sick, the idea that there's very little chance that they will live is not unreasonable. In that circumstance, several halachic authorities believe that you can say, look, I know I've had 20 people a day come in. I know there's someone who's coming into the hospital who really could benefit from a ventilator. So I'm going to withhold the ventilator from this person who's likely to be sick because I know someone's going to come in. Certainly if they're on the way in, that's reasonable. But here, the idea is even if you know they're coming in, that's something you can use as far as a triage decision is concerned about whom to provide therapy for. But again, there's only one minority opinion that suggests that you can actually remove somebody from a ventilator in order to give it to somebody else, even if that person is terminal. There are some things that others suggest you can do. For example, you can begin to turn down the ventilator as long as it doesn't result in immediate death, and then you're not required to turn it back up again. So you can decrease the oxygen content, you can decrease the respiratory rate, you can decrease what's called PEEP, the pressure that's used, and you're not required to turn it back up if the patient becomes ill. But you can't summarily disconnect a patient from a ventilator to give it to someone else. So if I have to summarize, the COVID pandemic has crystallized some complex moral and ethical issues that have been around for a while, but it's created a new urgency into trying to find a medical ethics and halachic framework for trying to analyze them. And there's been, although there's still some disagreements, there's been a general idea that there are certain principles of triage that can be applied and certain principles of withdrawal of therapy that shouldn't be applied halachically. There were some cases in New York City where this almost hit a very complicated crossroads because there were a couple of hospitals that were proposing to remove patients from ventilators without patient or family consent. And that would have been a situation where patient autonomy would have been violated, as well as halachic principles of actively intervening to end life rather than a passive intervention, and a violation of the principle of ein dochim nefesh b'fnei nefesh. So what was proposed in trying to deal with these potential situations was the idea of trying to work with hospital ethics committees, trying to come up with a compromise between halachic and medical ethical values. And I would say very fortunately that never came to a head because the solutions that were proposed never really made it to a place where there was any agreement. At Torah and New York Medical College, we were kind of faced with a similar situation. The advantage that we had is that we actually appointed the members of the ethics committee at our major teaching hospital. And so while they needed to strike the right compromise, had the situation ever arisen, they would have been able to utilize some of the principles you saw in that New England Journal of Medicine chart, even if they're not ones that are currently most favored by medical ethicists. Thank God we never reached the circumstance where we had to consider taking people off ventilators. And it looks like the pandemic is temporarily, at least, somewhat under control, although perhaps if there are questions about it, we can talk about what the future might hold. So thanks for listening. I'm going to first answer the one question that I see here, and then I'll turn it back over to Rabbi Babich to ask some more. The question is that dentists say there's still a shortage of PPE. They're back ordered. Sewing and distribution of cloth masks, PPE for healthcare workers, and so on. So first of all, I think it's great that you've been sewing masks so that the shortage of equipment for healthcare workers doesn't interfere with healthcare. I will tell you that my wife Kadish has been doing the same thing. She actually has created a slot for filters So the difference between a cloth or surgical mask and the N95 masks, which are used by healthcare workers, is that the N95 masks have filters that filter out 95% of the particles below a certain size. You can actually use an air conditioning filter or a vacuum filter that has some of the same principles. And if you create a slot in the cloth mask for that filter, it can improve the efficiency of the cloth mask. We've made some progress in the PPE shortage. Right now, the specific question that was asked was about dental offices. Dental offices are not open yet. They're relatively high risk. And we've been able, for our dental office, which has over 100 chairs, to secure PPE, and hopefully things are getting better. And our Fifth Avenue Synagogue member, who's been doing some sewing on her own, has told us that she uses also a HEPA AC filter or a floor swifter to try to create a better mask that will be more protective. So, Roy Babbitt, you had a couple of questions, and perhaps others do, so I'm going to turn it back over to you.
Yes, a couple of questions were sent to me, but first I want to thank you, Dr. Kadish, for your enlightening and stimulating presentation. It definitely demonstrates your versatility in fields, how you're able to jump between the Torah field. You're also deeply involved in the educational field and as well as the medical field. You have a lot on your plate, so we thank you for spending some time with us this evening. Now, a couple of things that came up, but just in terms of the masks, people have been asking, assuming you don't have the N95 masks that are reserved for those who are in the medical field, are the masks primarily to protect others or to protect yourself? Being that it's not really the strong enough filter to stop it from coming in, what's the real purpose of these masks?
So, very good question. Early on, the CDC and health authorities did not recommend wearing masks. And they did not recommend wearing masks for exactly the reason you said, which is that it was thought that if you weren't sick and coughing, that the mask wouldn't do anything. But it turns out that more recently there have been studies that have shown that that's actually not true. So for two reasons. First of all, talking can also spread the virus even without coughing or sneezing. And loud talking has a greater propensity for spreading the virus than normal talking. So why do I emphasize that? Because one of the things that we've been dealing with in reopening shuls is that it probably makes sense to have a greater distance from the chazan and the Baal Koreh than it does among congregants, because they are talking loudly. So in the guidelines that we're developing, we've actually suggested that there be 12 feet from the chazan and the Baal Koreh, as opposed to the normal 6 to 8 feet, because there are data now that loud talking, not just sneezing and coughing, can prevent the spread of the virus. So first of all, wearing a mask will protect others from you, not just if you're sick, but even if you're talking or singing. So there's a reason to wear a mask for that reason. And it turns out that more recent data have suggested that even for the wearer, a cloth mask has some protection. Not as good as the N95 mask, but has some protection. And as one of your shul members mentioned, and as I mentioned, if you put a filter in it, which is very easy to do, it's even better. So I think the current recommendation of wearing masks, everyone wearing cloth or surgical masks 100% of the time, is actually well justified and actually was 2 months too late on the part of the CDC.
So it does have a benefit both directions.
In both directions, yes.
There's also concern regarding blowing shofar has been raised. You know, how to blow shofar this year, that by definition, you're blowing out into the public.
That's right. So what I would say is for that, I would have even a further distance. And if you can do it outside, if that's a possibility, probably easier in some suburban synagogues than Fifth Avenue. Being outside, actually, the wind currents outside create a diffusion of virus that make it safer. But if you, I would, I think there'll still be some risk at Rosh Hashanah time. And if, hopefully with God's help, we're back in shul, I would recommend an even greater distance from the person who blows the shofar, maybe 20 feet, to protect everyone from that.
Interesting, thank you. And I have a number of more questions if you have
Sure.
the time. You began to address it again at the end of your presentation, but in terms of on a practical level, the major New York hospitals during when it was very intense and there was a large influx of patients, are you familiar with what guidelines they did do in terms of hospital beds and focusing on their care? Like, did they, the Torah halacha has one approach, and medical ethics has another. Even though there may be an overlap, are you familiar in the major hospitals in New York what guidelines they did use for those decisions?
So they definitely used three of the principles we talked about, which are the likelihood of success, the chance of survival, and they probably used age as well, even though that's halachically not a major factor.
If they had an older person and a younger person, they would put more attention on the younger person.
Correct. With the idea that they would have more years to come. The halachic retort to that is we don't really know how long someone's going to live. I mean, it's one thing if they have a medical illness, but young people die, older people live, and that's in Hashem's hands. So halachically, that principle is not considered important, but in terms of medical ethics, and as you know, that particular principle has been widely accepted. There are many countries where limited resources are allocated to healthcare, where you don't do dialysis over somebody 65 or over. You don't transplant somebody 65 or over, or in some cases 60 or over. And so that principle is well established and was utilized in some of the hospitals. As I mentioned, the idea of taking people off ventilators without their permission only became theoretical. To my knowledge, that never actually needed to happen.
Okay, thank you. And being that you're in the field of education, and we don't know how long this will disrupt the normal classroom model, but to your opinion, your assessment, to what degree will this have an impact on the students' development, both younger and older? Because, number one, not every student is able to sit in front of a computer for so long. There's also a social aspect to education, learning from one another. So as much as they're trying to compensate for the lack of in-person educational lessons, do you feel if this does prolong for a long time, that it will have an impact on certain children's development on an educational level?
So I'm going to talk separately about sort of K through 12 and college and universities. I'll start with college and universities, which I know kind of a little bit more about. I think everyone agrees that at many full-service colleges and universities, the campus experience is very important and is crucial. And that's why every college and university in the United States, both for didactic and financial reasons, is trying to get back to school as quickly as is safe. So I would agree with you that people believe that that's important to try to do. I will provide one caveat is, we have experience with online education going back over 20 years. We don't believe it's ideal for undergraduates, but we do it. And one of the important things to understand is that the way online education has been done in the last 2 months is not the ideal way online education should be developed. So there are a series of very advanced didactic tools to enhance the online educational experience, including group projects and different kinds of interactions that weren't possible to institute right in the middle of a semester. So it's possible to be better with online education than where we were, but I agree completely that the campus experience is important in colleges and universities, particularly on the undergraduate level. On the graduate level, I think it's a little bit different because the mentorship and the interactions perhaps aren't as important. And we're all trying to get back on the ground as quickly as possible, but we're doing the best we can to provide a quality education until then. As far as K through 12 is concerned, I think it's even harder there because you're dealing with larger numbers of teachers, with generally less resources on the school level and fewer resources on the student level, because the student population often exists in adverse circumstances. And so if we have to keep K through 12 education remote, it will definitely affect student development.
Mm-hmm.
And it's unfortunate. And I think that recognition led to the delay in closing New York City schools, which I think was a huge mistake, but it was based on some factors, at least, that were didactically important.
So how would it even be possible to open up the schools if the kids, you may argue are on a safer demographic than the staff, but how would you open the school and place all these staff members, at risk?
So it's really going to depend on the prevalence of the virus at the time that schools reopen. If it's very low, and you can, and at least the teachers wear masks and get some protection, and there's some distancing, I think it might be possible. What's the exact number? How low does the incidence have to be? I can't give you a number, but I think it's got to be pretty low, below 1%, for it to be anything approaching safe. And if you get down to the below 1% level, then you can do things like contact tracing and evaluation if somebody does get sick, and perhaps even screening. And that's what's going to be required to open the schools in the fall. I think there's going to be a strong, strong push to open the schools in the fall. But I also think that people have been sobered with 100,000 US deaths. People have been sobered to the point that they're not going to do it if it's totally unsafe.
Right. Okay, one final question. No one's a Navi, no one's a prophet to know how things are going to evolve. But based on your medical assessment, I encountered a doctor today who gave me a whole speech that we're in the second inning of a 9-inning game, and there's a long, long road ahead of us. What's your prediction? No one can know, but how things are going to evolve, and in terms of medically and in terms of society opening up.
So my first comment I have is anyone who tells you they're doing anything more than guessing is overinflating their level of knowledge. We have been basically wrong about everything. We were wrong about asymptomatic transmission. We were wrong about masks. The virus was percolating for weeks before we knew it. And then once it got there, 2 million people were going to die. 100,000 is terrible, but it's still different from 2 million. So we've been wrong about everything. So I know nothing. What I can tell you is that here's what I think will happen. I think there will be a recurrence in the fall of winter. It will continue to decrease over the summer. And it'll continue to decrease over the summer because we've cut down the number of people who are infected, and because there appears to be a modest temperature-related effect on the virus, the way there is on many viruses. That is, it's not that when it becomes summer, it suddenly kills everything, but it does appear to decrease the transmissibility, not just because you're outside versus inside, but because the temperature itself has a modest effect. So, and also, as I mentioned, outside is safer than inside. So I think we'll see a continued drop over the summer. I think in the fall and winter, there will be a recurrence. I think how much, I really can't say. I think we'll continue to have medicines like remdesivir that will provide incremental benefit. And I think there's a 25% chance we have a vaccine by the end of the year. Then it'll take some time to get promulgated. And a 50 to 60% chance we'll have a vaccine by the end of next year.
And just, I'm sorry, one final question. Everyone's running around getting these antibody tests. Now, in terms of getting the virus, contracting it a second time, generally that doesn't happen with viruses. So why is it that there's a opinion out there or concern that even though one has already fallen ill, that there is a chance that they could have contracted a second time? So
2 reasons. One is we've been humbled by the coronavirus. And there are some cases where you can get a viral infection again. And so people are concerned that maybe corona will be one of those. The other is that there are some cases where purportedly people have become reinfected. However, because the diagnostic tests aren't perfect, in those cases, it could be that the first test or the second test or the third test was an error. And what I mean by that is the following. To prove that somebody's been infected, you have to have a first test that says they were infected, a second test that says they have antibodies, and a third test that says they were infected again. So you have 3 different tests. Even though those tests are 95 to 99% accurate, which is about the best we're doing, if any one of those 3 is wrong, you will come to the conclusion that someone's been reinfected. Mm. So it's not clear to me for sure that that reinfection is common, but it's those examples that make us unclear. And the bottom line is, do I think you're relatively protected if you have antibodies? Absolutely. Of course, many of the antibody tests, the screening antibody tests that are being done, aren't anything close to 100% accurate. The full blood titers are pretty accurate, and you're relatively well protected if that's the case. Maybe, I can't tell you it's 100%, but you're relatively well protected. I would still take precautions, but certainly I think you can feel a little bit safer doing things if you have high titers of antibodies.
Could you spread it? Even if you have antibodies, could you spread it to someone else?
So there are a few cases which show that you can shed virus while you have antibodies. Again, that's just a few cases. So it's certainly unlikely. Can't tell you it's impossible, but it's unlikely.
Okay.
So I would still wear a mask. I would still be careful, but I think you can be a little less cautious if you're known to have antibodies.
Okay, Dr. Kadish, thank you so much for your very informative presentation. It's always wonderful to have you address us at the Fifth Avenue Synagogue. We got a little bit shortchanged because we're supposed to have you for 2 full days of Shavuos, but we'll try to make it up sometime in the future. And we want to thank you for your time, and we give you a bracha. You and your family should be healthy and safe, and continue doing the great work for the Jewish people and the world at large at the helm of a Torah college and university.
The same to you and the whole shul.
Okay, thank you so much, Dr. Kadish.
Take care.
Have a good night.